Okay, so hello again. So for the following minutes, I will be the discussant for Alessandra's wonderful and very inspiring presentation. So let me begin with the fact that when I read Alessandra's presentation, there were three main questions that came to my mind. So first, is it possible to handle the complexity underlying multimorbidity patterns? Second, conditions tend to cluster into patterns, but what are their interaction axes? And third, how can multimorbidity patterns inform prevention and treatment strategies? So let's start with the first question. Is it possible to handle the complexity underlying multimorbidity patterns? And I would like to bring this paper by Baylis, published in 2014, where the Baylis and collaborators very nicely identified the key contextual determinants of multimorbidity. So apart from the individual, the person with his or her biology, medical characteristics, culture, preferences, etc., we must not forget that individuals live within families with their ability to provide care to a higher or lower extent, with their social context, with their culture. But families also live within communities, with their physical, political, and economic environment. And at the same time, we have the healthcare system, with their delivery, care provision structure, the resources, the IT, the performance and incentive scheme. So unless we understand these multi-level interacting factors underlying multimorbidity, we will not be able to capture the complexity underlying multimorbidity. And indeed, what we see is that we get different patterns in different contexts. So I brought some examples from the literature. This is a study that we did in hospitalized patients, older patients in Spain. And one of the patterns that we got for these individuals, we called it the induced dependency pattern. And as you see here, there are several geriatric, very prevalent geriatric syndromes that cluster together, such as immobility, urinary incontinence, or delirium. And we hypothesized that it might be the case that because the common stressor, which might be the acute hospitalization, these health problems might cluster together in this specific setting, in this specific population. Another study that we did on immigrants in Norway, we saw that there was a pattern that we called a malignancy pattern, and it actually clustered together the most typical types of cancers. However, among Eastern Europeans, these most common cancer types were also clustered together with other different health conditions such as arthropathy, anxiety, or cervical pain. So we hypothesized that this might be due to the intricacy of cancer diagnosis in immigrant patients, immigrants from Eastern Europe. And there is some evidence showing that the number of consultations needed to derive these cancer patients to secondary care is higher among immigrants. And therefore, the chance to identify additional comorbidities would also increase. Another example, a study carried out among homeless US veterans. And what we see here is that the authors, one of the patterns that the authors identified was called the hepatic disease pattern. And of course, this pattern responds to very high prevalence of alcoholism, which brings together both liver but also gastrointestinal disorders. And we see that both oral, dental, and also orthopedic disorders cluster together in this pattern, probably due to the limitations that homelessness imposes on self-care. And last, another example, yet this time from the American Indian rural residents. This study is by John in 2003, and they identified a specific pattern that they called sensory motor pattern. And what we see here is that this cluster brings together three health problems: hearing problems, vision problems, and oral problems. And the authors hypothesized that what might underlie this pattern is the lack of coverage, the lack of health provision regarding hearing aids, dental prostheses, or even visual aids also. So basically, what we see is that indeed, because population subgroups are exposed to different levels of potential risk factors, well, the frequency of the specific combinations is very heterogeneous and very different depending on the context and the setting. So the two sub-questions from this block that came to my mind is, okay, so what are the analytical approaches that we should use to really capture these multi-level factors affecting multimorbidity patterns? And second, and how should we interpret these differences? Let me go to the second question. So conditions tend to cluster. I agree. So I do believe that conditions are not distributed randomly. I do believe that conditions tend to come together into multimorbidity patterns. But what are, and this time at the personal level, what are these interacting axes among diseases? And I wanted to take the example of a very much studied clustering of physical and mental diseases, which has been widely acknowledged. And in fact, we know a lot about the mechanisms underlying the coexistence of these conditions. And if we look at this scheme, we see that, well, we do have medical, biological factors such as pain, disability, chronic inflammation, but there's also the impact of treatment, pharmacological therapy, both because of side effects or because of a lack of adherence to treatments. And of course, lifestyles also play a role, but lust. And in the middle, we have the psychosocial factors, the lifelong psychosocial factors also playing a role when underlying this clustering of diseases. And in fact, it has been shown that feeling dissatisfied with life, low self-esteem, low sense of coherence are predictive of multimorbidity. And conversely, living in a family and being part of a large social network are protective of multimorbidity patterns. So again, two questions that come to my mind in this second block. So we know that there are factors, but which are the factors that prevent people from accumulating diseases belonging to one same pattern of multimorbidity? And second, what is the biological substrate of this interacting axis? Because unless we know the biological substrate, or this will be very helpful to answer our third question. That is, so how can multimorbidity patterns inform prevention and treatment strategies? And to answer this question, or at least to put some additional questions on the table, I wanted to bring here the work by Richardson, 2014, where the authors give us some clues as to which dimensions determine evidence-based decision-making about treatment for individual patients. And they talk about three different axes. We have baseline risk on the x-axis, which means the baseline risk unless we treat that specific condition or those specific conditions, the responsiveness, which means the responsiveness to the treatment, and the vulnerability, which means the vulnerability to the secondary effects, to the complications of a certain treatment. And these authors remind us that usually in randomized trials, what we see is that most of the individuals that are included in RCTs belong to this small dark square with a very low vulnerability, a high responsiveness, and a high baseline risk. However, the reality of our multimorbid patients is rather here, in this lighter box, with people with a higher vulnerability, and of course, a lower but not zero baseline risk, and a lower but still not zero responsiveness. So what do we do with these individuals? Well, we agree that if we're able to show by means of this multimorbidity pattern approach that conditions tend to cluster and that there is a statistical significant association or interaction going on, well, then it's very likely that these conditions will potentially impact the three dimensions of baseline risk, responsiveness, and vulnerability that we just spoke about. Now the question is, maybe future research might want to answer as to, okay, and what is which estimates, which specific estimates, in which direction, and by what magnitude are they affected when diseases cluster together? So, to wrap up my presentation, three very short answers to the three initial questions. I do not think there is such a thing like standard patterns of multimorbidity. We see that patterns of multimorbidity, we get different patterns of multimorbidity for different contexts and settings. I also agree that methods need to be either developed or combined or modified to better capture, to be more sensitive to these underlying interactions among diseases, and whether these interactions are driven by individual level factors or more contextual factors. And last, I think it is a good idea that future research on multimorbidity patterns is framed within the 3 dimensions of risk, responsiveness, and vulnerability. So thanks very much for your attention.